the MAIC analysis that we did comparing ARCHES to ARANOTE suggested a greater benefit for enzalutamide over darolutamide in delaying the primary endpoint, which was radiographic progression-free survival. This stood up in the sensitivity analyses and in the docetaxel naive patient population, and was also a consistent effect for other secondary endpoints such as time to PSA progression, time to CRPC, time to next anti-neoplastic therapy. So very consistent signals suggesting that perhaps enzalutamide in this analysis has greater efficacy in those major endpoints. Now, overall survival could not be compared directly in these trials because the ARANOTE study has not been analyzed or reported for overall survival, and the follow-up of the ARANOTE study is very immature. On the other hand, the ARCHES study is much more mature, and we have presented the survival benefits of enzalutamide, which we've published several years ago, and then much more recently I presented at ASCO the 5-year survival data, which suggested a large survival benefit, particularly for the de novo high volume patients, an absolute survival benefit of 3 years, but similar overall survival benefits regardless of whether there was high or low volume disease, whether there was metachronous or synchronous disease. So all patients are benefiting in terms of treatment intensification in this setting. Most oncologists, when they are taught about reviewing evidence and statistics, are quickly taught not to compare across trials directly, because trials may have important imbalances or differences in design or patients enrolled. And so it's very difficult to just look at 2 different phase 3 trials and compare them directly. But what a matching adjusted indirect comparison does is it allows for a statistical method for doing this kind of cross trials comparison, where we do our best to match the trial populations, the factors that are associated with prognosis and outcome in the trials, where one of the trials we have individual patient data, another trial we have kind of the aggregate data, and we do our best to restrict the patient population from one study to match the other study, and then adjust for what we call confounders that might influence differential outcomes from one trial or another. That's what we did for our comparison from the ARCHES study and the ARANOTE study to assess whether enzalutamide or darolutamide may have different efficacy in patients with metastatic hormone-sensitive prostate cancer. Yes, I mean, we identified major confounders or effect modifiers, we call them in MAIC language, to be disease volume, whether a patient presents with de novo metastatic disease or relapsed metastatic disease, visceral metastatic disease such as liver metastases, and a number of other factors were included, such as geographical region, age. We did an additional sensitivity analysis for ECOG performance status. ECOG is difficult in phase 3 studies because one of the selection criteria is that basically everybody has an ECOG performance status of 0 to 1, and very few patients are enrolled with poor ECOG performance status. And that was true in the ARCHES and ARANOTE studies. So we tried to adjust on those confounders. We also did a sensitivity analysis where we restricted on the docetaxel naive patient population. The ARANOTE study did not include prior docetaxel, and the ARCHES study was about 17 or 18% of patients had prior docetaxel before they were randomized to ADT plus or minus enzalutamide. When a provider and patient are making decisions between which AR pathway inhibitor to use, safety is very important, but so is efficacy. And so trying to pick the right ARPI for your patient kind of balances that overall net risks and benefits. Certainly, Enzalutamide from our data suggests a survival benefit and perhaps a slightly greater progression-free survival benefit. Darolutamide may have fewer side effects, particularly to older patients, where the risks of falls and fractures and fatigue and neurocognitive effects may be lower. Drug-drug interactions as well as fractures may be lower darolutamide. So for some patients, darolutamide is a good choice, and for some patients, enzalutamide is a good choice. It's very individualized. Well, there is no further follow-up plan for the ARANOTE study, so I think, what would be ideal is to have some comparative effectiveness work that's done, in the community or in other countries that are testing the various comparative effectiveness in a randomized way of the various AR pathway inhibitors. That would really be gold standard level one evidence for really saying which drug is safer, which drug is more effective, which drug has better survival benefits, what has a differential quality of life. Doing randomized trials is still the gold standard here in practice. We're limited, though, by the funding for such studies. Most of these studies are not going to be done or funded by industry. And so it kind of is really on us as a community, federal agencies, international agencies to conduct those comparative effectiveness studies. Those can often take 5 or 10 years. And so having these kind of MAIC results in the meantime can help guide treatment decision making.